Hello everyone. So I hope all of you are doing good. We have another very high yield vignette for all the USMLE steps, very basic information that all of us have to know. So let's start. A 35-year-old man with a 6-year history of HIV infection comes in with progressive shortness of breath and a dry, non-productive cough for about 10 days. He has been adherent to his antiretroviral therapy and his most recent CD4 count is 320 cells per microliter. He also mentions that recently he started taking trimethoprim sulfamethoxazole prescribed for recurrent sinus infections. On examination, he has low-grade fever, fine crackles bilaterally, and his oxygen saturation is slightly reduced at 93% on room air. The chest X-ray shows diffuse, bilateral, interstitial infiltrates, and his labs reveal a mild peripheral eosinophilia. So the question asks, which of the following is most likely diagnosis? Let's go through the options one by one. So like all of us know, Pneumocystis jirovecii pneumonia is a very common opportunistic infection that can happen in HIV patients. However, let us see if that is the correct answer. It's the wrong answer. So the presentation looks exactly like Pneumocystis jirovecii pneumonia, subacute shortness of breath, non-productive cough, and those diffuse bilateral infiltrates. But here's the key. His CD4 count is 320, so that's too high for PCP to occur. Remember, PCP pneumonia is classically seen when the CD4 count drops below 200 and especially below 100 if untreated. Also, he's already on trimethoprim sulfamethoxazole, right? Which is the prophylaxis for PCP, so that means PCP cannot be the right answer. So even though the vignette sounds like it, this one can't be the PCP because of the key fact that they have mentioned the CD4 count to be 320. So this is how the questions can trick you. So it's always important to pay attention to the key details that are required for the diagnostics of each of the opportunistic infections. Let's go to the next option, which is B, cytomegalovirus pneumonitis. That is also a wrong answer. Now, CMV is a big opportunistic infection in HIV. It can affect the lungs, retina, GI tract, or even the CNS. However, CMV pneumonitis almost never occurs until the CD4 count drops below 50. Those patients are usually severely immunocompromised and often have additional signs like retinitis, esophagitis, or colitis. This patient has none of that. His CD4 count is well above 300, and it is clearly mentioned that he is adherent to his antiretroviral therapy. So when a patient is taking their antiretroviral therapy medications, there's no reason why the CD4 count would drop below 50. So in our patient, it is not below 50, and hence we cannot choose this as the correct answer. So remember that if there is an HIV patient with CD4 count of less than 50 and there is painless vision loss with floaters and cotton wool spots, cotton wool exudates noted on fundoscopic exam, then this is CMV retinitis, another very high yield diagnosis that you should remember. It is painless vision loss with floaters, and then there are cotton wool exudates seen on the fundoscopic exam. Okay, so let's go to the next option, which is a Mycoplasma pneumonia infection. So that's the wrong answer. Mycoplasma pneumonia can absolutely cause a non-productive cough and interstitial pattern on imaging. So it's worth thinking about. It's a good option to rule out because it's so similar. But Mycoplasma pneumonia tends to cause community-acquired pneumonia in young, otherwise healthy adults, often with ear pain or bullous meningitis, and typically has patchy or perihilar infiltrates bilaterally, not uniform ground glass opacities on bilateral lung fields. Also, the presence of eosinophilia doesn't fit mycoplasma. So while this is a good option, it doesn't match the case perfectly. So let's go to the next option. Let's jump to option E, which is tuberculosis, before we visit option D, which is drug-induced hypersensitivity pneumonitis. Tuberculosis is also a wrong answer. Tuberculosis can certainly occur at higher CD4 counts, even about 200, so it's worth checking. But the classic TB picture is productive cough, night sweats, weight loss, and upper lobe cavitary lesions or miliary nodules on chest imaging. Here, the chest X-ray shows diffuse interstitial infiltrates, not cavitations. There's no mention of exposure, chronic symptoms, or even systemic symptoms that are typically associated with tuberculosis. So this presentation doesn't match that of tuberculosis, hence we rule it out. Now for the final option that is left, drug-induced hypersensitivity pneumonitis, that is like trimethoprim sulfamethoxazole induced hypersensitivity pneumonitis. Let's talk about that. So this is the correct answer. Everything fits perfectly to the vignette according to this option. The patient was recently started on trimethoprim sulfamethoxazole, a sulfa drug known to cause drug-induced interstitial pneumonitis or hypersensitivity reactions in some patients. That explains the gradual dyspnea, non-productive cough, bilateral diffuse infiltrates, and very importantly, the peripheral eosinophilia. The timing of the symptoms soon after starting the medication seals it. So in a lot of the USMLE questions, if you see that a patient was started on a new medication and then they started experiencing certain new symptoms, even if you might not know the answer, this is an important. It can act as an important clue in a lot of vignettes. So keep that in your mind. So his immune status isn't low enough for opportunistic infections, but the medication itself seems to have triggered the inflammation in the lung tissue. Hence, this is the correct answer. Remember that whenever there is peripheral eosinophilia, a lot of the times these can be drug-induced reactions. So that becomes a very important point in this particular vignette. Now, let's take a moment to discuss a very important aspect for USMLE, which are uh, treatment options that we have when the CD4 count, or the medications that we use as prophylactic treatment in patients when the CD4 counts drop below 200. As you can see in the slide, I have tabulated 3 important scenarios that can occur when the CD4 count drops below 200 cells per microliter, right? So the most high yield turning points in HIV management is when the CD4 count drops below 200. That is when the body loses its ability to mount effective cell-mediated immunity, and that is also true for the lungs. Cell-mediated immunity is not working in the entire body and also in the lungs. That's why this exact threshold is where the CDC defines AIDS. When CD4 count drops below 200, it's not just HIV, we call it HIV-AIDS now. Okay? The patient may still look well, but the risk of infections skyrockets, opportunistic infections. So before that infection can even start, we start primary prophylaxis using certain medication. The first line prophylactic drug for PCP is trimethoprim sulfamethoxazole, or commonly called TMP-SMX, or a common brand name is Bactrim. So we usually give it 1 double-strength tablet every day as a form of prophylaxis. The single medication protects against 2 major infections, so Pneumocystis jirovecii and Toxoplasma gondii, which becomes relevant later when the CD4 count drops below 100. So what if the patient has severe sulfa allergy or develops Stevens-Johnson syndrome, or like the vignette showed in our patient where the patient develops a hypersensitivity pneumonitis? Then we have some other backup options. So the most common alternative is called Dapsone. But before starting Dapsone, we should always test for G6PD deficiency, because Dapsone can trigger hemolysis in G6PD deficient patients. Another option is Atovaquone, which is useful for both PCP and Toxoplasma gondii prophylaxis. And in some cases, we can use aerosolized pentamidine. But remember that since it is aerosolized and inhaled by the patient, it protects the lungs and not the brain. Hence, it does not prevent toxoplasmosis. Once the patient starts effective antiretroviral therapy and the CD4 count rises above 200 for at least 3 months, we can safely stop TMP-SMX. So that brings us to the end of the discussion about this. We shall have further discussions, more detailed discussions about opportunistic infections in HIV themselves. Until then, I hope your preparation goes well. All the best. Bye.